Let us discuss a clinical case of a patient undergoing robotic-assisted laparoscopic cholecystectomy, focusing on the important anesthesia considerations from preoperative assessment to induction, pneumoperitoneum, robotic positioning, intraoperative management, and safe extubation. Robotic cholecystectomy is minimally invasive from the surgeon's perspective, but from the anesthesiologist's perspective, it presents several unique challenges. The combination of carbon dioxide pneumoperitoneum, increased intra-abdominal pressure, steep reverse Trendelenburg positioning, limited patient access after docking, and the requirements of the robotic system can significantly affect respiratory and cardiovascular physiology. Therefore, careful preparation and continuous anticipation of complications are essential. Consider a 52-year-old patient scheduled for elective robotic-assisted laparoscopic cholecystectomy for symptomatic cholelithiasis. The patient has obesity and gastroesophageal reflux disease, with no major cardiac or pulmonary disease. On preoperative assessment, the patient is hemodynamically stable, with acceptable baseline oxygen saturation and routine laboratory investigations within acceptable limits. The airway assessment should be performed carefully because obesity, limited neck movement, obstructive sleep apnea, or other airway difficulties can make airway management more challenging. We should also assess cardiovascular and respiratory comorbidities, including hypertension, ischemic heart disease, chronic obstructive pulmonary disease, diabetes, and obstructive sleep apnea. Because this is a laparoscopic procedure, fasting status and aspiration risk are particularly important. Patients with gastroesophageal reflux disease, obesity, delayed gastric emptying, or other aspiration risk factors require appropriate planning. Essential medications such as antihypertensives, anti-anginal drugs, bronchodilators, and steroids should. Now let us move to induction of anesthesia. General anesthesia with a secured endotracheal airway is preferred because robotic laparoscopic surgery requires controlled ventilation, and the airway becomes difficult to access once the robotic system is docked. If the patient has significant aspiration risk, a rapid sequence induction may be considered according to the clinical situation. After adequate preoxygenation, anesthesia can be induced with agents such as propofol and fentanyl, followed by a neuromuscular blocking agent such as rocuronium or cisatracurium. Adequate depth of anesthesia and muscle relaxation should be established before pneumoperitoneum is created. A properly positioned and secured cuffed endotracheal tube is essential. We should confirm bilateral air entry, capnography, airway pressure, and tube position before proceeding. An important point in robotic surgery is that the airway must be secured extremely well. Once the robot is docked, access to the patient becomes limited. Any accidental displacement or disconnection of the endotracheal tube can therefore become a major emergency. All intravenous lines, monitoring cables, airway connections, and the endotracheal tube should be checked carefully before docking. Once the abdomen is insufflated with carbon dioxide, significant physiological changes begin. Pneumoperitoneum increases intra-abdominal pressure, commonly to approximately 12 to 15 millimeters of mercury. Carbon dioxide is absorbed from the peritoneal cavity into the circulation, resulting in an increase in arterial carbon dioxide and potentially causing hypercapnia and respiratory acidosis. The anesthesiologist should therefore closely monitor end-tidal carbon dioxide and adjust ventilation accordingly. Increased minute ventilation, usually by adjusting respiratory rate and sometimes tidal volume, may be required to maintain an appropriate end-tidal carbon dioxide level. The infographic recommends a target of approximately 35 to 45 millimeters of mercury, while the exact target should always be individualized according to the patient's condition. Pneumoperitoneum also increases intra-abdominal pressure and pushes the diaphragm upward. This decreases functional residual capacity and lung compliance and increases airway pressures. Therefore, the same ventilator settings that were adequate before insufflation may no longer be sufficient after pneumoperitoneum. Robotic cholecystectomy commonly requires a steep reverse Trendelenburg position, often around 20 to 30 degrees, sometimes with additional lateral tilt, depending on the surgeon's requirements. This position facilitates exposure of the upper abdomen, but has important cardiovascular consequences. Reverse Trendelenburg causes blood to pool in the lower extremities and decreases venous return to the heart. Reduced venous return can decrease preload and potentially reduce cardiac output. This effect may become more pronounced when combined with increased intra-abdominal pressure. Therefore, blood pressure and heart rate should be monitored carefully, and hypotension should be treated appropriately. At the same time, the position may improve diaphragmatic mechanics compared with Trendelenburg, but pneumoperitoneum continues to increase airway pressures and reduce lung compliance. The overall respiratory effect is therefore determined by both the position and the pneumoperitoneum. Let us now summarize the major physiological changes. From the respiratory perspective, pneumoperitoneum elevates the diaphragm, decreases lung compliance, increases airway pressure, and can cause hypercapnia. From the cardiovascular perspective, increased intra-abdominal pressure and reverse Trendelenburg can reduce venous return and cardiac output. Depending on the patient and anesthetic depth, compensatory sympathetic activation may produce tachycardia and increased vascular resistance. From the neurological and intracranial perspective, increased carbon dioxide can cause cerebral vasodilation and may increase intracranial pressure in susceptible patients. Therefore, significant hypercapnia should be avoided, particularly in patients with intracranial pathology. Temperature management is another important consideration. Robotic procedures may be longer than conventional laparoscopic procedures, and anesthesia-induced impairment of thermoregulation, combined with exposure and administration of unwarmed fluids, can contribute to hypothermia. Active warming with appropriate warming devices and fluid warmers may therefore be required. During the procedure, lung protective ventilation is important. A practical strategy is to use a relatively low tidal volume, approximately 6 to 8 milliliters per kilogram of predicted body weight rather than actual body weight. Respiratory rate can then be adjusted to maintain an appropriate end-tidal carbon dioxide. Peak airway pressure and plateau pressure should be monitored. An increase in airway pressure after pneumoperitoneum is expected, but a sudden or excessive increase should prompt assessment for problems such as endobronchial intubation, bronchospasm, pneumothorax, reduced lung compliance, or excessive intra-abdominal pressure. PEEP can be used according to the patient's respiratory mechanics and oxygenation requirements. The goal is to maintain adequate oxygenation while minimizing ventilator-induced lung injury. Next is hemodynamic management. Blood pressure should be monitored continuously, particularly in patients with cardiovascular disease or significant physiological changes during insufflation and positioning. In high-risk patients, invasive arterial blood pressure monitoring may be appropriate. Hypotension during robotic cholecystectomy can result from reduced venous return, anesthetic-induced vasodilation, excessive depth of anesthesia, bleeding, or reduced cardiac output. Management should be directed toward the underlying cause. Depending on the situation, adjustment of anesthetic depth, appropriate fluid administration, or vasopressor therapy may be required. Fluid management should be goal-directed rather than excessive. Although adequate intravascular volume is important, unnecessary fluid loading can contribute to tissue edema and postoperative complications. The aim is to maintain euvolemia. Another critical consideration is the depth of anesthesia. The anesthetic should be titrated using clinical parameters and, when available, processed EEG monitoring such as BIS. The objective is to provide adequate hypnosis and analgesia while avoiding unnecessarily deep anesthesia that can contribute to hypotension and delayed recovery. Neuromuscular blockade is particularly important in robotic surgery. The surgeon requires a stable and immobile surgical field, and even small patient movements can interfere with robotic instruments. Therefore, adequate muscle relaxation should be maintained throughout the procedure. When available, quantitative neuromuscular monitoring using train-of-4 monitoring can help guide the depth of blockade and ensure appropriate reversal at the end. Now, we come to one of the most important unique aspects of robotic surgery, the robotic system itself. Once the robot is docked, access to the patient becomes significantly restricted. The anesthesiologist may not be able to immediately reach the airway, chest, or intravenous lines. Therefore, before docking, every connection must be checked. The endotracheal tube must be firmly secured. Intravenous lines should be functioning and accessible. Monitoring cables should have sufficient length and should not be compressed or pulled during positioning. The eyes, pressure points, and extremities must also be protected. Communication between the anesthesiologist and surgical team is essential. The surgical team should understand that if an airway or cardiovascular emergency occurs, the robot may need to be undocked rapidly. Emergency undocking and access to the patient should therefore be considered before the operation begins. What complications should we anticipate? First, hemodynamic instability can occur because of pneumoperitoneum, reverse Trendelenburg, anesthetic drugs, or bleeding. Second, hypercapnia and respiratory acidosis can develop because of carbon dioxide absorption. Third, airway pressures may increase and oxygenation may deteriorate because of reduced lung compliance. Other potential complications include subcutaneous emphysema due to extraperitoneal carbon dioxide, although this is relatively uncommon. Gas embolism is rare but potentially life-threatening. A sudden unexplained decrease in end-tidal carbon dioxide, cardiovascular instability, hypoxemia, or other abrupt changes should raise concern for serious complications and require immediate assessment. Postoperative nausea and vomiting should also be anticipated because laparoscopic surgery is associated with an increased risk of PONV. Appropriate risk assessment and prophylaxis should be provided. Postoperative pain management should use a multimodal approach, combining appropriate systemic analgesics with local or regional techniques when indicated. Finally, we come to emergence from anesthesia. This is a critical stage. Before extubation, pneumoperitoneum should be released, and the patient should be returned to a safer neutral or supine position as appropriate. Neuromuscular blockade must be adequately reversed, preferably guided by quantitative monitoring. A train of 4 ratio of at least 0.9 should be confirmed before extubation. The patient should be fully awake, able to maintain the airway, and have adequate spontaneous ventilation and protective airway reflexes. Particular caution is required in patients with obesity or obstructive sleep apnea because postoperative upper airway obstruction and hypoventilation can occur. After extubation, oxygenation, ventilation, consciousness, hemodynamics, pain, nausea, and airway patency should be monitored closely. Any signs of airway edema, laryngospasm, hypoventilation, or residual neuromuscular blockade should be identified and treated promptly. To summarize this case, robotic cholecystectomy may appear to be a minimally invasive procedure, but it creates several important anesthetic challenges. The major issues are carbon dioxide pneumoperitoneum, increased intra-abdominal pressure, altered respiratory mechanics, reduced venous return, reverse Trendelenburg positioning, restricted patient access after robotic docking, and the requirement for adequate muscle relaxation. The key to safe anesthesia is anticipation. Before induction, assess the airway, aspiration risk, cardiopulmonary comorbidities, and positioning requirements. During induction, secure the airway and all intravenous and monitoring connections. During pneumoperitoneum, anticipate hypercapnia, increased airway pressures, and hemodynamic changes. During the robotic phase, maintain adequate ventilation, hemodynamic stability, temperature, anesthetic depth, and neuromuscular relaxation. And before extubation, ensure complete reversal, adequate ventilation, and full consciousness.